This talk is about nervous system congenital malformations and perinatal injuries. Here are the objectives for this class. You do not need to read them. We will use them as a chart for our talk. The talk will be conducted using conversational and question and answer formats. We will first use a conversational format to talk about the classification of nervous system congenital malformation. There are many classifications that attempt to organize nervous system congenital malformations, but I have not found one completely satisfactory. In this talk, I will use the one I have found most useful. Nervous system congenital malformations can be divided in 5 major types: persistence of remnants of transient structures, closure failure, cleavage failure, formation defects, and histogenesis errors. Now, I want to make 2 important points. First, it is important to stress that all types of nervous system congenital malformations have a strong genetic factor. But in addition, closure failure have a clear relation to nutritional factors related to diminished folate availability, such as it occurs with the use of cholesterol-lowering medications and other medications that block folate absorption, folate malabsorption, increased body demand for folate, and insufficient intake of dietary folate. Environmental factors are also very important in the production of closure defects, such as the use of folic acid antagonists, as in valproic acid and other anticonvulsants, high blood sugar, as it may occur in maternal diabetes, hyperthermia, either because of infectious or going into a sauna, and excessive vitamin A. Malformations due to closure failure are to a great extent preventable, since so many of them are related to insufficient folate to meet the demands of the growing embryo or fetus. So, folic acid 0.4 mg per day should be taken by all sexually active women before and during pregnancy. The dose should be increased to 4 mg per day if there is a maternal history of prior birth with closure defect, strong maternal family history of closure defect, or the mother is taking medication known to interfere with folate. The second point I like to stress is that the different types of nervous system malformation usually do not occur in isolation. Closure failure is usually when the central nervous system is primarily involved, associated with cleavage failure, formation defects, and histogenesis errors. Cleavage failure leads to secondary formation defects and histogenesis errors. Formation defect lead to secondary histogenic errors. Only primary histogenic errors may occur in isolation. Now, let's go back to continue engineering our classification. This frame shows the classification where we left it off. So let's begin by talking about persistence of remnant of transient structures. Persistence of remnant of transient structures can itself be divided in 5 types. Those that involve the primary streak producing sacral teratomas, those involving the notochord producing chordomas, those involving the neuroenteric canal producing neuroenteric fistula or cyst, those that involve the caudal eminence producing tethered cord and related conditions, and those involving the Ransk pouch epithelium producing craniopharyngioma. The conditions produced by persistence of remnant of transient structures are discussed in other videos, hence they will not be addressed during this talk. So let's go back to the major nervous system congenital malformation chart. The next major type of malformation we will address is closure failure. Closure failure is further classified in relation to the extent of involvement. I have introduced a fetus to show you the rationale behind this classification for closure defects. The line just added represents an axis going from the vertex to the coccyx. We talk about total closure failure when the closure failure extends from the last coccygeal vertebra to the lamina terminalis. The lamina terminalis is the part of the brain formed by the rostral-most midline structure of the neuroaxis. We talk about dorsal closure failure when the closure failure involves an area localized from the last coccygeal vertebra to the vertex. We talk about ventral closure failure when area involved is between the vertex and the lamina terminalis. Closure failure abnormalities can also be arranged according to the layer or tissue involved. Failure of closure of the neural plaque leads to not only failure of nervous system closure, but also to closure failure of the neighboring mesenchyma and skin. Failure of mesenchymal and skin closure, once the neural tube is closed, leads to secondary involvement of the nervous system, which may go from destruction in the case of anencephaly to displacement in the case of myelomeningocele. Failure of mesenchymal closure with normal closure of the neural tube and skin leads to closed spinal dystrophism and midline brain defects characterized by displacement of the nervous system structure but no contact between the nervous system and the environmental surface. Closure failure can thus produce craniorachisis, spinal dystrophism, and brain dystrophism. These three conditions will be addressed during this talk. After closure failure, the next major type of nervous system congenital malformation is cleavage failure. Cleavage failure are restricted to prosencephalic development. It can involve one type of cleavage, but usually involve all three types of proencephalic cleavages, although one type of cleavage defect may predominate. The types of cleavage are transverse, sagittal, and horizontal. These cleavages occur almost simultaneously, but not at the same pace. Cleavage failure produces holoprosencephaly spectrum. They will be addressed later on in this talk. Going back to the major types of nervous system congenital malformation chart, we can see that after cleavage failure, the fourth major type of nervous system malformation is formation defects. Formation defects are of three types based on anatomical localization. Those involving the lower sacral coccygeal region, among which we have tethered cord and related conditions. The second types are posterior cranial fossa formation defects. Posterior cranial fossa formation defects can be divided in two types. Those involving the cerebellum, among which we have four frequent malformation syndromes: Chiari malformation, Dandy-Walker malformation, Joubert syndrome, and cerebellar defects. The other type of posterior fossa defect involves the brainstem, the most frequent being Mobius syndrome. Mobius syndrome is covered in the neuro-ophthalmology class. The third type of formation defects involve a structure in the anterior and middle cranial fossa. In this group, we have agenesis of the corpus callosum. This condition will be addressed in this talk. The fifth major type of nervous system congenital malformations is histogenesis error. Histogenesis errors can be partitioned in four types: errors in proliferation, which can lead to microcephaly and macrocephaly; migrational errors, errors of organization, and errors in synaptogenesis. Now, I want to call your attention to migrational errors. They can be divided into those that involve the neural crest progenitor cells and those that involve the neural tube progenitor cells. Neural cell progenitor errors may occur in the cerebrum, cerebellum, brainstem, and spinal cord. The other two remaining histogenesis errors, as we previously mentioned, are organization and synaptogenesis. These later two types of errors can also be classified based on anatomy to those involving the cerebrum, cerebellum, brainstem, and spinal cord. Now we will change to the question and answer format. First question. Take a look at this image and choose the best answer. A. Myelomeningocele. B. Holoprosencephaly. C. Craniorachisis. D. Lysencephaly. I have in this frame represented the three-layer structure characteristic of the third week gestational age with the notochord. The ectoderm above the notochord, under the indirect influence of substances released by the notochord, becomes the neural plate. The formation of the neural plate is the first stage in a process called primary neurulation. Once the neural plate is formed, it undergoes differential growth. The edges of the neural tube grow at a faster rate than the area between the edges, thus producing the neural folds. The neural folds produce a shallow canal. This constitutes the second stage of primary neurulation, called the shaping of the neural plate. Now, the region between the ectoderm and the neuroectoderm, called the ectodermal neuroectoderm interface, starts growing disproportionately. This growth raises the edges of the canal, but as this happens, the cells in the interface, indicated by the arrow, and on both sides, become neural crest progenitor cells, whereas those in the center, bracketed by the magenta line in this frame, become the neural tube progenitor cells. The growth at the edges continue more and start to bend towards each other. This represents the third stage in neurulation, called the bending stage. Shortly after, the edges of the neural tube fuses. This marks the beginning of dorsal induction, the name given to this fusion of the dorsal aspect of the embryo overlying the neural cord. This fusion is considered the beginning of the fourth stage of primary neurulation. The advance of fusion of the neural axis has been compared to the closing of a zipper, but it is not as simple as that. The first site of fusion is the region of the future neck, yet the closing does not take place as a simple caudal and rostral sequence. Other areas not contiguous with the area initially fused also begin to close as represented in this frame. Ultimately, the neural tube is left with two polar holes, the anterior and the posterior neuropores. The first one to close is the anterior neuropore, doing so by about 25 days. Then the posterior one closes by about 27 to 28 days. So that is when things go well and it ends up as a perfectly smooth back, as you can see in this frame. But when neurulation goes bad, the closing does not take place, fusion does not occur. When this failure is total, the patient develops a condition called craniorachisis, a condition not compatible with life. Thus, the answer to this question is C. Next question. Please take a look at this image and choose the best answer. A. Dandy Walker malformation. B. Fetal alcohol spectrum disorder. C. Chiari type 2 malformation. D. Lysencephaly. Drinking alcohol during pregnancy, especially before mother knows that they are pregnant, leads to fetal alcohol syndrome. But some women are at higher risk. Those older than 30 years of age with a long history of alcoholism, those with poor nutrition, those having one child with fetal alcohol syndrome, and those with genetic susceptibility due to a slow alcohol metabolism. Patients with fetal alcohol syndrome disorder have typical faces: microcephaly, widely spaced eyes, small palpebral fissures, retrograde tract ears. Retrograde tract ears, as indicated by this arrow, refers to parallel arrangement of the upper ear folds. These patients also have low nasal bridge, maxillary hypoplasia, upturned nose, smooth philtrum, thin vermilion border, and micrognathia. We must then ask the question, why alcohol produces abnormal facial features? The cause of the facial features in patients with alcohol fetal syndrome can be traced to a histogenesis error of migration involving the neural crest progenitor cells. As you recall, once the neural tube fuses, two types of cells are created: the neural tube progenitor cells that go on to form most of the central nervous system, and the neural crest progenitor cells. These cells' journey is one of the most perilous journeys of all cells in the human embryo. Here I have represented them. Here I have added all the roads they take and one that they don't. The one they do not go through is the one to the central nervous system. But they go on to become all peripheral nervous system cells, including neurons, supporting ganglion cells and Schwann cells, melanocytes, the postganglionic suprarenal cells, and more importantly for our story, they also contribute to the facial skeleton and muscle formation. This road is blocked in patients with fetal alcohol sequence, leading to the characteristic facial features that we previously mentioned. Now I'd like to consider the effect of alcoholism in the central nervous system. Holoprosencephaly was associated with fetal alcohol syndrome back in 1991. Another condition associated with fetal alcohol syndrome is agenesis of the corpus callosum. Here we can see a dysplastic corpus callosum. Here I am indicating a partial agenesis. A partial agenesis in the distribution in this frame indicates an anterior or metatarsal formation defect. The distribution of the agenesis in the MRI here presented is not consistent with holoprosencephalic spectrum, a cleavage error, nor with destructive lesions. We will see why in the next few frames. This is a sagittal cut of a brain where we can clearly see the corpus callosum, which I have enlarged here to label its parts. The rostrum is the thin line I am pointing to in this frame, and now mark with a cream line with 2 arrows. The genu is right anterior to the rostrum. I have used a yellow and a green line to mark its extension because they tend to develop at slightly different times, as you will soon see. The body is by far the longest segment, which I have signaled with a magenta line. The splenium is in the back, which I have marked by a dark violet line. In this frame, I have reduced the size of the picture of the corpus callosum with the lines indicating its different parts. In the new figure, I have incorporated the red arrow representing axon destined to form the corpus callosum. The primordial region that will, with the arrival of the axons, become the corpus callosum is represented in magenta. On gestational day 72, those axons start crossing. The curved line I have just introduced represents time from 72 to 115 days gestational age. By day 73, a significant number of fibers have crossed in the region of the anterior body, indicated by the aqua arrow in the corpus callosum figure. By 74 days, the crossing fibers from the superior part of the genu, indicated here by the magenta arrow, appear. Shortly after, those forming the lower part of the genu start crossing, and so do fibers from more posterior regions of the body. The backward growth of the body of the corpus callosum continues as the days and weeks go by. Now, close to 115 days, the splenium appears, as indicated by the arrow. And the last part to develop is the rostrum, to which I am indicating here and here. Hence, in this MRI, based on the deposition of fibers, we can say that fibers stop crossing rather early in development of the corpus callosum. On about day 74, as a consequence of a formational defect. In cases of holoprosencephaly, the genu is more often affected than the splenium, and in destructive lesions, the rostrum is usually preserved. Before leaving the subject of agenesis of the corpus callosum and going back to talk to you about fetal alcohol syndrome, I'd like to tell you 2 additional important facts about agenesis of the corpus callosum. The first deal with mesial gyra morphology. Here you can see side by side a normal brain and one with agenesis of the corpus callosum. Notice the gyral configuration in the brain with no corpus callosum. The gyra run straight and they reach the ventricles. This is not the case in the normal brain. The second fact is that there is a syndrome called Aicardi syndrome, which occurs in girls, that you can make the diagnosis of agenesis of the corpus callosum by ocular fundoscopy. If you do fundoscopy in one of your patients and you see colobomas as the one in this frame, the patient is likely to have agenesis of the corpus callosum. Patients with Aicardi syndrome often have seizures. Now I will go back to the patient with fetal alcohol spectrum disorder to tell you that nervous system malformations in patients with fetal alcohol spectrum are not restricted to cleavage failure producing holoprosencephaly, formation defect producing agenesis of the corpus callosum, but also to histogenesis problem. such as proliferation errors, cerebral migration errors, cerebellar migration errors, as well as organization and synaptogenesis errors in the cerebrum and cerebellum. Fetal alcohol spectrum disorders involve other organs including the heart and the hand. Most characteristic finding in the hand is the hockey stick crease, as you can see in this frame. So the answer to this question is B, fetal alcohol spectrum disorder. Please take a look at this image and select the best answer. A, encephalomalacia, B, holoprosencephaly, C, anencephaly, D, lysencephaly. On day 24, the embryo has 3 primary vesicles rostally and 2 open neuropores. By day 25, the anterior neuropore closes by the action of genes upon the regional medium. The closure of the anterior neural tube influences the closure of the mesenchyma and skin tissue overlying it. When the anterior neuropore closes well, the rostral embryonic area, mainly the mesenchyma and skin, is induced by the closing of the neuropore to form the forehead and face as shown here. When things go wrong and the anterior neuropore fails to close, to induce mesenchymal skin closure or both, then we have as a consequence an ill-formed prosencephalon that grows outside the skull. This is called exencephaly. In such cases, the nervous tissue exposed to amniotic fluid is gradually destroyed, leading to anencephaly. So the answer to this question is C. Next question, please look at this image and choose best answer. A, spina bifida occulta, B, myelomeningocele, C, myelocystocele, D, mielocele. At 25 days, as we have seen, the anterior neuropore is closed. It has induced the proper closure of the forehead and face. The posterior neuropore is still open. At 28 days, the posterior neuropore is closed. Neurulation is complete. And shortly after, in a matter of hours or maybe less, the mesenchyma and skin above the closed posterior neuropore closes too. When the closure of the posterior neuropore goes well and induction of the mesenchyma and skin proceeds in a normal fashion, as we have just described, the back of the infant looks smooth and well formed. I will now schematize the structures present at the level of this line to better explain the different types of spinal dystrophism. At the indicated level, we will see the skin, the subcutaneous tissue, the erector muscles, the spinous process, the lamina, the transverse process, the vertebral body, the spinal cord enclosed in the arrows in this frame, the central canal, the ventral horn whose development from the basal plate has been influenced by the sonic hedge gene, and the dorsal horn whose development from the alar plate has been influenced by transforming growth factor beta, including the bone morphogenic protein. The area enclosed between the double layer of arrows heads facing each other is the meninges. I have placed the arrow and the circle to show you the area I will enlarge, as you can see here. The arrow indicates the spinal cord parenchyma in the original figure and now in the enlarged figure. Now the arrow is pointing to the bone corresponding to the spinal process in the original figure and now in the enlarged figure. Now I am indicating the pia mater. Notice that the color of the rectangle matches the color of the line representing the pia. Now I am indicating the arachnoid matter. The space enclosed by the arrows is the supraarachnoid space. This space is filled with cerebrospinal fluid and traversed by arachnoid trabecula. The dark green line represents the meningeal dura. Just below, the black line represents the subdural space, which is a virtual space because in the living it is not present. Now I am indicating the bony dura, matter which is attached to the vertebra, so it is often referred to as the vertebral periosteal layer. Now I am indicating to the epidural space. When development goes well, all these structures are perfectly formed. What about when things go wrong? When things go wrong, we have a condition called spinal dysraphism, which I have already mentioned. This condition may consist of a failure of primary neurulation, failure of dorsal induction, or both. Hence, spinal dysraphism may manifest in many different ways, the most severe of which is a myelocele. In myelocele, the failure of posterior neuroproclosure leads to an abnormal position of the spinal horn by the side of the anterior horns, and exposure of the neural plate to the external environment during extrauterine life. This is a photograph of such an occurrence. Notice that you can see the presence of the sulcus limitans, which is the line of demarcation between the sensory and motor neuronal groups. Myeloceles is at times referred to as myelochysis and rachis, especially when the area involved is large. So the answer to this question is D. Next question. Please look at this image and select best answer. A. Spinal bifida occulta. B. Myelomeningocele. C. Myelocystocele. D. Myelocele. As you recall, once the posterior neuropore closes by day 28, in a matter of hours or maybe less, the mesenchyma and skin above closes too. When this goes wrong, in addition to a myelocele, we may find a whole gamut of abnormalities, such as a spinal bifida occulta. In a spinal bifida occulta, the spinous process is missing, but neither the meninges or the spinal cord are involved. This condition is often accompanied by an abnormal patch of hair. An abnormal patch of hair can also indicate a more serious spinal dysrhythm, so it must always be investigated. On other occasions, spinal bifida occulta may be heralded by a skin discoloration. In this frame, we have enlarged the area of the discoloration to show you a little hair coming out of the abnormal skin patch. You can now see, as when pressing around the patch, we find a hole. As before, such findings may indicate an occult spinal bifida, but often indicate a more severe pathology, such as a meningocele. In meningocele, the meninges protrude through a hole created by the missing spinous process, as you can see in this frame. Meningoceles may be closed if the sac is covered by skin and subcutaneous tissue, as it is in this patient, or open. It is called open because the skin and the subcutaneous tissue is missing and the meningeal sac is exposed to the ambient. If the spinal cord has moved into the sac, then it is called a myelomeningocele, closed if covered by subcutaneous tissue as shown in this frame, or open if it is not, as you can see here. In some cases of a spinal dysraphism, the spinal cord is split. A part remains in the spinal canal and the other part is found in the protruding meningeal sac. In these cases, the spinal canal presents between them. This frame shows an open myelocystocele. This one is a closed myelocystocele. This is an example of such a case. Notice the skin discoloration, which is, as we previously mentioned, a common sign of underlying pathology. Also notice the apparent thinness of the layer covering the bulge. This is a sagittal MRI where you can see the bulge and displays spinal cord. This is transverse cut of the same patient going through the lesion, as you can see. In this frame, I have added the figure. Here you can see a segment of the spinal cord as illustrated here. Here, the other part of the spinal cord as illustrated here. And here, what you see is the stretched and enlarged central canal as illustrated in the figure. During surgery, a sac forming a continuous structure with the central canal was found, as you can see in this frame. So the answer to this question is C, myelocystocele. Next question, which of the following is not true? A, neural tube defects can be detected by ultrasound. B, open neural tube defects are associated with high amniotic levels of alpha-fetoprotein. C, amniocentesis for neural tube defects detection are most reliable between 15 and 20 weeks gestational age. D, neural tube defects are prevented by folinic acid. Ultrasound will detect spinal dystrophism that protrude from the skin surface, as you can see in this frame. The lumbosacral region is the most common site of such abnormality. Maternal blood, usually obtained from 14 to 16 weeks gestation, can detect high alpha-fetoprotein levels in cases where the fetal nervous system tissue is exposed to the amniotic fluid. Amniocentesis done between 15 and 20 weeks gestational age may show elevated alpha-fetoprotein and acetylcholinesterase levels. Remember, malformations due to closure failure are to a great extent preventable. Folic acid 0.4 mg per day should be taken by all sexually active women before and during pregnancy. A higher dose should be used for high-risk ladies. So the answer to this question is D. Please take a look at this image and choose the best answer. A, cleavage failure. B, formation defect. C, closure failure. D, none of the above. The patient has an obvious mass that you can see in the MRI. But more importantly, you see that something is missing. The patient has an anterior encephalocele. Anterior encephaloceles are more common in Oriental people. This cartoon shows the normal relation between the nose and the brain. The image just added shows an anterior encephalocele. I am going to use this new frame to show you a slightly different condition. In this condition, the brain protrudes into the nose. This is called an anterior oronasal encephalocele. This frame has a sagittal and a transverse MRI of a patient with an anterior oronasal encephalocele. You can see the brain falling into the nose. And in the transverse MRI of the brain, you can see the brain is displaced anteriorly. This pathology represents a closure failure involving the ventral region and the mesenchymal tissue. Thus, this is a cerebral dysraphism. The damage to the brain is most likely secondary to physical factors. Closure failure can also involve the dorsal aspect of the embryo and be restricted to the mesenchyma. As you can see in this patient with a posterior encephalocele, notice the size of the mass, the MRI finding reflects the physical constraint produced by the defect. In this frame, I have introduced a new patient with a high posterior encephalocele. Notice that the encephalocele is smaller and higher than the prior case I showed you. Notice the location of the encephalocele in the MRI. As you can see, this patient also had hydrocephalus. This new frame shows a patient with an atretic encephalocele. As you can see in this image, the encephalocele is surrounded by a dark patch of black hair. The atretic encephalocele can be seen in the MRI. The tissue inside is a mixture of glial cells and connective tissue. Now I'm going to show you a case that really blew my mind. You can see the case in this frame. Notice the prominent lump just above the nose, and here from the side. When I saw this patient, the first thing that came to my mind was an anterior encephalocele, but it was not. The lump was due to the absence of a muscle called corrugator supercilii. The mass is the subcutaneous fat protruding through the area of the missing muscles. Hence, this lesion can be labeled a pseudo-meningocele. So the answer to this question is C. Next question. Take a look at this image and choose best answer. A. Dandy Walker. B. Holoprosencephaly. C. Chiari type 2 malformation. D. Lysencephaly. This patient has a cleavage defect. The term cleavage is used for prosencephalic changes induced by environmental and genetic factors, leading to the formation of the cerebrum and the face. There are three types of prosencephalic cleavages. Transfer cleavages produces the diencephalon and the telencephalon. Sagittal cleavage produces the right hemisphere and left hemisphere. Horizontal cleavage yields eye and nose position and morphologies. These cleavages are strongly influenced by the sonic hedgehog gene pathway. This pathway shapes the telencephalic structures to produce a normal cerebrum. Here we can see the interhemispheric fissure, two separate frontal lobes and two separate frontal horns, two separate basal ganglia, two separate thalamus only joined by the intermediate mass, two separate temporal horns, and two separate occipital horns. This is what occurs normally. In the absence or misfunction of the sonic hedgehog gene pathway, holoprosencephaly of variable degree will occur. In the least severe form, called lobar, the interhemispheric fissure is at least partially present. The frontal lobes are separated, although with an abnormal shape. The basal ganglia of both sides are joined. The thalami are separated, but the mass intermedia may be thicker than usual. The corpus callosum splenium is preserved, and the temporal lobes are well formed. Next in severity is the semilobar type. Here there is no interhemispheric frontal fissure, and the posterior one is ill-formed. The frontal lobes are united. There is one basal ganglia mass in the middle of the brain, one thalamus, no corpus callosum, but the temporal lobes are preserved. The third and most severe type is called a lobar. In this group, there is no interhemispheric fissure frontally, nor in the back. There is a single dysmorphic lateral ventricle, one basal ganglion, and one thalamus. In all three types of holoprosencephaly, diabetes insipidus, another type of hypopituitarism, and hypothalamic dysfunction may be present. The photograph just added belongs to a patient with a lobar prosencephaly. These facial characteristics are microcephaly, hypotaylorism, nose with one hole, and cleft lip and palate. This frame has the multiple faces we may encounter in patients with different degree of holoprosencephalic cleavage defects. You do not need to learn their names. These pictures are from a website called Science Direct. Notice the patient with single central incisor. This finding is important because such patients may have endocrinological hypothalamic problems. So the answer to this question is B. Please take a look at these images and select the best answer. A. Diocele, B. Mesocele, C. Medial telocele, D. Mielocele. This patient has a large head and a thin enough cortex to allow light placed on one side of the skull to go through the other side. This MRI shows a large third and a normal small fourth ventricle. This is consistent with the diagnosis of aqueductal stenosis. Here I have represented the embryonic brain at 45 days gestational age. The name by the side corresponds to the cavities. I will now indicate the structures they give rise to. The lateral aspect of the telocele becomes the lateral ventricle. The region of the telocele between the medial eminence and the telencephalic wall, as indicated by the arrow, become the foramen of Monro. The rostral most part of the telocele becomes the frontalmost part of the third ventricle. The tissue of the telencephalon between the lateral telencephalic vesicles become the lamina terminalis and the anterior wall of the third ventricle. The diocele forms most of the third ventricle, except most rostral part, which, as we just mentioned, is formed by the telocele. The mesocele becomes the aqueduct of Sylvius. From the metacele and the mielocele arises the fourth ventricle. So the answer to this question is B. Next question. A large posterior fossa occurs in A. Dandy-Walker malformation, B. Arnold-Chiari malformation, C. Joubert syndrome, D. None of the above. This chart, which we have seen multiple times, shows the major divisions of the nervous system congenital malformations. As you can see, the fourth type of nervous system malformation corresponds to formation defects. This new frame includes the different types of formation defects. Formation defects involve the posterior fossa, and in it they can involve the cerebellum. These questions name probably the three most frequent type of malformation in this group, which are Chiari malformation, Dandy-Walker malformation, and Joubert syndrome. One way to arrange the many cerebellar malformations is to divide them according to the height of the tentorium, here seen in a sagittal brain cut, and here without the brain structure. So we can divide cerebellar formation defects into two groups: those with normal or low tentorium position and those with high tentorium position. I have here included some of the conditions that produce each type of anomaly. The only ones you are likely to find in your exam are Joubert syndrome, Arnold-Chiari malformation, and Dandy-Walker syndrome. I will first address Joubert syndrome. Patients with Joubert syndrome have a broad forehead, arched eyebrows, droopy eyelids, which this patient does not have, widely spaced eyes, low-set ears, and a triangular-shaped mouth. In addition, patients with Joubert syndrome have hypotonia, hyperventilation, ataxia, abnormal extraocular movements, and mental retardation. Two MRI signs are pathognomonic of Joubert syndrome: the molar sign and the bat wing sign. As you can see in this MRI, the structure pointed by the arrow looks like a molar tooth. The structure now pointed in the sagittal MRI, with a little imagination, looks like a bat wings. That concludes our discussion of Joubert syndrome. Another cerebellar formation defect with latent thorium is Arnold-Chiari malformation. There are many classifications of this condition. I would use the following: Chiari 1 malformation without syringomyelia, Chiari 1 malformation with syringomyelia, Chiari 2 malformation without myelomeningocele, Chiari 2 malformation with myelomeningocele. We will first talk about Chiari type 1 malformation without syringomyelia. Patients with Chiari type 1 malformation without syringomyelia have no unusual facial characteristics and usually present no symptoms prior to adolescence. After adolescence, they may develop headaches as well as neck and shoulder pain. They can also develop ataxia. The MRI of these patients show peg-like cerebellar tonsil displacement into the cervical canal through the foramen magnum. Now we will address Chiari type 1 malformation with syringomyelia. Patients with Chiari type 1 malformation with syringomyelia have no characteristic facial features. Symptomatology will be dominated by the syrinx. When cervical, the most common site of syringomyelia, patients experience cap-like bilateral symmetrical loss of pain and temperature with preservation of position, vibration, and stereognosis. The MRI of patients with Chiari 1 malformation with syringomyelia show tonsil displacement and the syrinx. Now we will talk about Chiari type 2 malformation without myelomeningocele. Patients with Chiari type 2 malformation without myelomeningocele have no characteristic facial features. They may present at any age with headaches, neck and shoulder pain, lower cranial nerve dysfunction, upper motor neuron symptoms, and ataxia. The MRI of patients with this condition show at least evidence of cerebellar tonsil and vermis displacement into the cervical canal. These patients often have aqueductal stenosis. The fourth condition we will be referring to in this group is Chiari type 2 malformation with myelomeningocele. Patients with Chiari type 2 malformation with myelomeningocele present with all the pathology found in patients with Chiari type 2 malformation without myelomeningocele. But in addition, they have manifestation produced by the myelomeningocele. This is an MRI of a patient with Chiari type 2 with myelomeningocele. They present with paralysis and sensory loss at and below the lesion. And if present, as usually it is, there are signs of non-communicating hydrocephalus. This ends our discussion about Arnold-Chiari malformations. The next condition I would like to mention is Dandy-Walker syndrome. These are two photographs of the same patient with Dandy-Walker syndrome. Transillumination above the posterior fossa produces a round, light circle with limited projection. Transillumination at posterior fossa produces a light projection far from the source, as you can see. The MRI of patients with Dandy-Walker malformation show cystic enlargement of the fourth ventricle with elevation of the tentorium and agenesis of the cerebellar vermis. Non-communicating hydrocephalus may also be present. So the answer to this question is A. Please take a look at these images and choose the best answer. A. Dandy-Walker malformation. B. Chiari 1 malformation, C. Chiari 2 malformation, D. Lysencephaly. The patient is microcephalic. You can tell because the face is wider than the head. When looked at from above, the head shape resembles a number 8 because of the small bitemporal diameter. Facial features are dysmorphic, as you can see in this photograph. These patients usually have seizures and are mentally retarded. This patient has lysencephaly. Lysencephaly is an histogenesis error of migration involving neural cells progenitors at the cerebrum. This is a cartoonish representation of a well-developed neocortex with its organized 6 layers. This is a cartoonish representation of an abnormal neocortex due to migrational error. There will be no stratification, no cellular organization, and poor synaptogenesis. Failure of migration is always associated with organization and synaptogenic errors. MRI of the brain is diagnostic. The brain surface is very smooth, the lateral ventricles are big, and the brain is shaped as a number 8. So the answer to this question is D. Please take a look at this image and choose best answer. A. Intracranial bleeding. B. Cerebral infarction. C. Kernicterus. D. Lysencephaly. Under the guise of this question, we will discuss 3 conditions. Lysencephaly has already been discussed. The first one is intraventricular bleeding. Intraventricular bleeding is the most frequent neonatal intracranial bleed. The anatomical area most often involved is the head of the caudate. The most important predisposing factor is prematurity. This is a maturity line. It indicates different terms used in neonatology. Notice that the counting starts with the first day of the last menstrual period. Intraventricular bleeding is more frequent at 28 weeks than at 32 weeks gestational age. Clinical manifestations are often absent, but when present, most of the time they manifest by hydrocephalus or signs of encephalopathy. Intraventricular bleeding often expands to produce intraparenchymal bleeding. Intraparenchymal bleeding, as seen in this MRI, usually occurs in the centrum semiovale. Predisposing factors for intraparenchymal bleeding are bleeding diathesis, vascular malformations, aneurysms. Frequent clinical manifestations are seizures and encephalopathy. The second condition we will discuss is cerebral infarct. Cerebral infarcts are rather frequent in neonates. They usually occur with an arterial distribution in one of the middle cerebral arteries. They have a triangular shape. Predisposing factors are hypercoagulation states, polycythemia, maternal hypertension, and maternal cocaine use. Clinical manifestations include hemiparesis and seizures. The third condition we will discuss is bilirubin encephalopathy. Bilirubin encephalopathy results from non-albumin bound unconjugated bilirubin entering the brain, instead of becoming conjugated bilirubin and being excreted. In the brain, the bilirubin affects and stains the basal ganglia, hence the term kernicterus, meaning nuclear icterus. But bilirubin also stains and affects the subthalamic nuclei and the hypothalamus. In addition, other nuclei that are often stained are the cochlear and the vestibular nuclei in the brainstem. Clinical manifestations reflect the involvement of these structures and consist of dystonia, athetosis, opisthotonus as you see in this patient, and irritability. Other manifestations such as seizures are likely to occur in this condition. So the answer to this question is C. Thank you very much for your attention.